Center. Dr. Salim will speak about Pertussis Resurgence, a wake-up call for public health. Dr. Salim, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon, everyone. I think Dr. Muhammad said just the last lecture, it's difficult to present before lunch. I think it's more difficult to present after lunch. So thank you, Aman, for the nice introduction. Thank you, Al-Musa Group, for the nice invitation. It's the first time in Al-Ahsa. It's a very nice place and quiet. Just happy to be here. So as you can see the title, I'm going to speak about Pertussis. So I want to know first how much we have general practitioner, primary healthcare, and if any gynae, obstetrician. So it seems to be all ID, so it's more difficult to present Pertussis for ID. So I'm going to start with a little bit weird question. So from a public health community level, transmissibility concern, which one you think it's worse, Pertussis or COVID-19? Pertussis. So because I'm presenting for Pertussis. A good answer. So I will take you to a fact. So if you want to see the infectivity or how infectious Pertussis, knowing that Pertussis is a very communicable disease, or the secondary attack rate is about 80% among a susceptible population. If you want to compare it to COVID-19, which being, I would say, the top infectious form is Omicron, it doesn't even reach 50%. So it's very transmissible even when you compare it to COVID-19. And I use COVID-19 just not to bother you. I know you don't want to hear anything about COVID anymore, but it's, I would say, one of the latest infectious agent that we can relate to, and I think it's still in our memory. So it's far away above COVID-19. Infectivity period, so Pertussis will be infectious right away when you start to have flu-like illnesses, before even you get the classical Pertussis cup, which is going to be one of the, I would say, the first diagnostic clinical methods. The infectivity might persist 3 weeks after getting this classical cup. In general, it would be around 5 weeks. When you compare it to COVID, it's 10 days period. I know it's going to be more in immunocompromised population, but that would give you a hint how infectious or how transmissible Pertussis. And seeing these facts, to leave you without wonder why we are still struggling with Pertussis, despite its, we have a good vaccine for the last 40, 50 years. Pertussis is still present in our community and still be presented in such conference. So it's a very huge burden globally, about 24 million annual cases and more than 150,000 mortality rate. Despite our global coverage is around 86%, which is a good coverage. However, it's not optimal considering the variability of developing and well-developed country data. I wouldn't also bother you, since I know we are all ID, wouldn't go to clinical presentation and more of pathogenesis. I'm sure you're aware of it, but I will take you to more of facts and numbers. So this is the incidence rate globally, and again, to refer to being quiet when it's come to Pertussis, we still have, I would say, a good community level transmission when it's come to Pertussis. And again, this is a global data. I wouldn't give you the data that you need in your region to be able to estimate what's going on. So mindful that the dipping gap around COVID-19, which is going to be most likely related to testing capability, reporting, and it's not a real decrease. However, there have been a concern about more incidents after the COVID-19 or the pandemic. This is a more, I would say, concise data when it comes to European, well-developed country. So they were able to decline it early 2000s and 2010. However, after 2015, there have been an increment, and it's been COVID-based in many other areas, considering our data. And again, the dipping in COVID-19 is still there. However, it's very clear they re-spike after COVID-19 pandemic, and it was worse than the previous level. this is our data. So we managed to bring it down again with our vaccine, whole cellular vaccine and a cellular vaccine. We bring it down to almost zero, 2010, 2015, and after that we start to get more cases, and I think 2019 was one of the worst years just before COVID. Then we get the following precautionary measures, following diagnostic methods availability, and following reporting issues. So just getting this example will let you know if you don't test for it, if you didn't report it, then you will feel you are controlling. So that's going to be applied in many other areas that we can use in future. So if you can see 2023, it's very low number. I would say clinically or observationally, we are seeing cases in 2023 and even 2024 where we don't have data here. So we'll go to a more data in the next slide. So this is published data 2024. It's almost reported from the same source that was feeding the WHO data. So you can see the 2019 column. It's jumped from 24 on the left side to 207. So this is a huge jump. Are we getting this curve right away and we couldn't document it during COVID? It could be, by the way. No other data to go over what we have in hospital days, but I would present one of the tertiary hospitals in Riyadh. So this is a monthly cases in a very tertiary hospital in Riyadh. They still have cases, and if you sum all these columns, you will get almost 30 cases. So is that a huge number in one hospital?
Yes.
Huge. And it will be more concerning if you have the baseline. So the baseline in that hospital, it was 5 cases anyway, and it's jumped to 30. So this is King Faisal, by the way, Riyadh. So I'm sure we are seeing this in many other hospitals. Do we have the diagnostic capability? Do we have the type of patients that would reflect what's going on in the community? I would say if we are getting a lot of that, or I would say patients representing the community, we'll have more than 100 variants. So we are surging, and I think that's the first part that's gonna. I ended up here just convincing you we are surging. We are really surging. The second two part, I will go through why we are surging, and I will concentrate on some of the factors that will elaborate why we are surging, and at the end of the presentation, I will talk about what we can do in our setup to mitigate the risk, slow the progression. I'm not sure you will be able to drop it and make it zero in the near future. Considering we are surging despite we don't have a community level surveillance. So we are just seeing the patients coming to our hospital, and we will be lucky if we have the respiratory multiplex that we can get the pertussis among them or pneumonia benign, which is not available in the primary health center. And that's why I ask if there is any general practitioner. They are the one who's seeing those patients. We don't see it in our tertiary hospital where we have all the diagnostic tests. Most likely the entry point for those patients are the primary health center. They don't have any capability to diagnose. And I'm sure they will treat empirically, considering we have a pathognomonic diagnostic cuff that we didn't need the testing. So there is no need to document, by the way, and we go clinically. So we are missing a lot of cases in the purpose of documenting, knowing the level, and maybe taking more action towards it. And again, recently there have been a lot of data about the typical presentation. So we might not have that typical cuff that were helping us for the last 40 to 50 years. So why we are surging? There is a lot of reasons. The first thing is that pertussis by nature is a critical outbreaking disease. Every 5 years there might be an outbreak, and this is the nature of the bacteria or the organism. And again, we are growing more susceptible population. We are widening our range of age, and at the same time, we are having more community with a less long-lasting vaccine. Considering we moved from whole cell vaccine to a cellular vaccine that wouldn't last long, and we'll talk about it in the coming slides. Many atypical cases that will be definitely empirically held in the preventive measures. And again, we are having a new phase. Again, I'm going to talk about it at the end of the presentation. regarding macrolide resistance. So the first antibiotic or the only option that we have is we are going to lose it. And definitely, we are improving our diagnostic methods and accessibility. That would enhance the share, but this is I would say, two-sided sword. So definitely we are diagnosing and getting easy access, but that definitely will help us in isolating those patients, treating them, treating the exposed contact tracing members. So it should be working in the both sides. So I wouldn't depend on it as a whole determinant factor for the sale. The last two reason, I think that this is the way that we need to go, and this is where we have the room of improvement. I think the first 5 or 4 reasons, we can't do anything about it. So this is by nature. So waning immunity after immunization due to a cellular vaccine, I think we can have a way of improving this. And adolescent and maternal vaccination, I think this is the most important in our setup, and we'll prove it soon. So starting by immunity waning, so as you know, the natural infection will happen, I would say, 4 to 20 years lasting immunity. When it's come to the vaccine, either whole cellular or acellular, it's far less than that. So we should expect a waning immunity in our vaccination-driven antibodies. This is a slide which show you when we start to introduce the cellular, we start to have a higher number. Just to give you a flavor of sensing, there is an increment of incidence after introducing a cellular vaccine. What would be the coverage of vaccine? Since we are talking about the vaccine and waning immunity, globally there is a clear gap in vaccination. When it's mainly, you can see the slide in African area, and even in the area around us, just in the north and southern Saudi Arabia, we still have a lower coverage. And again, this is just only talking about the first year of life. This is a global data. What about our data? So we have a good coverage. 97 for pertussis is perfectly nice for the first year of life. Considering we are not covering the 2 month, the early 2 month of life, where it's the highest risk, we are not covering the adolescent, we are not covering mothers. So we'll go and see them. So we are doing great, and I would say from 2 to 12 months of life, our babies are well covered, 97%. If this data is right, that's great. And we need to deal with the other gaps. Is that right? Is it a good coverage? So this is a data that would talk about antibodies, so seroprevalence, how much we have in our community. So this is back in 2007, and I would assume most of their antibodies related to either natural infection or a previous or another kind of vaccine, which is a whole cellular. So you can see the first year, the 6 year and 17 years. So the first year of life, they have a good immunity. I would say they are getting either maternal plus minus the primary series of DTaP. It's going down when it's come to 6 years. However, in 17 years, they have non-protected level. At that time, it's not protected. Despite they were having a different vaccine, they have a different or a higher natural infection rate. So I would assume if we do this study after 2024, we might have a zero antibodies at the age of 17, which is in female is a child-bearing age, which we might need a more antibiotics. So antibodies. Following this concern, that's our national immunization schedule, stating a dosing of Tdap at the age of 11 years, and we need to press more on making a mandatory recommendation at any visit. When we talk about maternal vaccination, so do we need it, and how much of our, just before we recommend the vaccination, so how much of our childbearing women are seropositive to the point that will make it a protective level that we can easily translate it to our newborn. So again, the aim from maternal immunization is to cover the first 2 months of life. It's the highest risk, and it's the only time that we can cover it with the vaccine. So the only way is to go through the mother. So this is a very nice study being done in Najran by Dr. Al-Aid in 2018. he collected almost more than 300 pregnant women, and he managed to get their sample at the third trimester, and 72% of them, they were having seronegative. And even the seropositive, we didn't investigate how much of them they have a good protective level. So we could easily detect any level above 10 international units per ml. However, we need more than 50, 60 to be a protective level for the person, rather than transferring this immunity to the baby. So we're almost dealing with nothing. So this is just right away before we introduce our recommendation regarding maternal vaccination. Again, another study being done in Riyadh at the same time, almost 2019, and they managed to collect almost the same number, and they found almost 50%, 48% of them, they have no detected level. And among the remaining 51%, 80% of them, they have a very low level, which is not protected. So just do the calculation, we have no protection. So then we start to have our recommendation about third trimester vaccination. So I think that's a very huge gap. We need to cover it. And the most important is how much we are compliant with this and how much we are doing it for any our pregnant ladies. There have been a concern about maternally driven antibody that will intervene with the vaccination, as it's clearly in this slide. So after the red zone of inheriting antibodies from the mother, the vaccine wouldn't be mounting the same antibody. However, I would say there is a good way to prevent this and rectify it. With the following vaccine at the first year, maybe at the school age and adolescent age, there is a way to prevent it, but there is no way to rectify the first 2 months of life lacking immunity. So what we are doing when it's come to I'm missing a slide. And there have been a study done in Al-Ahsa. I'm missing the slide before this, but I would say there have been a recent study in Al-Ahsa talking about what would be the awareness among pregnant women when it's come to DTaP vaccination. And it reflects a huge, good knowledge of awareness about the importance of it, but there have been a huge concern about the safety of the vaccine during the pregnancy. We are still lacking the trust of the vaccine, and that's not a secret following what we have even during the pandemic. Another kind of study surveying an OB-GYN team about what's their uptake when it's come to prescribing the vaccine to the pregnant woman, the information, the refusal rate, is there any extra information they need, and among private sector, is there any issue with the reimbursement? So their answer was the following. And by the way, this is a very recent study, it's 2023. So 38%, they were afraid from a patient refusal. Family, they were refusing. Or pregnant women, they were refusing the vaccine. I would say the same reason. It's the concern about the safety during pregnancy, and as nature, any mother will be very careful during pregnancy. Physicians, 38% of them, they said, we need more information for ourselves to be able to educate and counsel and reassure the mothers. And again, they need to know more about the national recommendation. So, and there is a lot of reasons just going down the grade. On this side, a very shocking data. So 47% among those of the gynae team, they were not aware about national immunization protocol. At the same number, 47%, they thought they are not the one who should do that. So we have a huge communication gap. We need to fix it. And as if you didn't do that, and I think this is a very important study. It's a small scale study, but it's very representative, knowing what's going on in the community. So as much as you do in regulation, if you didn't follow it up and make sure that's happening, you wouldn't manage anything. This study, they came up with a brochure. I like this brochure. There is an easy language. They present more infographic data to assure the mothers, and with a good representation of the high-risk area and side effect and about the safety. So it was about education, and I think it's very essential to disseminate an evidence-based practice among physicians and definitely creating a lot of educational materials when it's come to the mothers. I would love to see more of Arabic version, honestly, but I think that's important when it's come to such intervention during pregnancy. It wouldn't be easy implemented without a huge effort in once it's come to education, reassurance, and communication. Other population, rather than adolescent, rather than first year of life, they are still have been a good reservoir for pertussis, helping in transmission. And going back to the same study, they were lacking the antibody data. A recent study, this is an old one, a recent study done in Western region by Dr. Rahat and Dr. Shamrani, they managed to collect, I would say, around 800 middle-aged male from 18 till 60. The level on the left side is 0.68, so this is the level of antibodies, and this is the age. So 80% of them were below 60. So among our community, male sides, they are not protected. So they might get the infection, and they help to transmit it among the community. And this age is a highly I would say, ambulating community. They are the active population going around and helping in a community transmission. So we are lacking maternal vaccination. We are lacking a huge bunch of our community without a protective level, despite our very extensive infant vaccination program. Adding to that, there is a huge age shift. So classically, pertussis has been an infancy disease. Recent data from China, and the way to come is through China. 50% of the last 2 years, pertussis has been in a middle age, between 6 and 18 years, more than 50%. So it's not anymore infancy disease. Considering our population age, that's a huge population that we need to target. And again, this is the same recommendation about adolescent vaccination, just mindful the red box. The last concern that I want to share is this. We have a new strains with macrolide resistance. So what we have been doing in primary health centers, getting empirically macrolide might not work anymore. And this is a very recent study from China. They have the MT195, which is macrolide resistant gene. It's totally resistant to the first and second option, azithromycin, erythromycin. So that's a good concern that we need to consider, and we might be looking for it in the near future. One final study being done in our Middle East region following what was the burden and what would be the lack that we need to fix. And again, they emphasize what we talk about, maternal immunization and enhanced surveillance. So currently we are having a huge surge. We have a current vaccine. We have no other option. We need to work on it. In the short term, we need to increase the vaccine coverage, as it's the only option that we have now. And the only option will have to decrease the pertussis incidence. In the long term, I think we need to come up with a new vaccine with a long-lasting immunity. At this stage, I will conclude if there is any way to stop or mitigate or slow down the surge, we need to control the source, we need to interrupt the transmission, and we need to protect the more susceptible population through early identification, prevention, and management. And again, vaccination is vaccination. Nothing being achieved in medicine like what vaccine achieved. Our target are adolescent and maternal group. If we didn't manage those two populations, we will not be able to stop the surge or even control it. And definitely we need more data. What we are having incidence, real data. What's our vaccine coverage? At least special population outside the infancy time. And definitely more, I would say, sophisticated data about resistance. Do we have any resistance? I think that's going to be a crucial element in the future, inshallah. At this stage, I will conclude, and thank you.